Hello, my name is Cassidy Krieger,
Hi, I'm Anaya.
and we looked into the prediction of post-stroke cognitive impairment using machine learning. Okay, to introduce our topic, I'm going to explain what post-stroke cognitive impairment is, which is also known as PSCI. It refers to the cognitive deficits that occur following a stroke in individuals who did not have dementia before the event. It is a major determinant of functional dependence among stroke survivors. The prevalence of PSCI varies widely, ranging from 20% to 75%, depending on factors such as ethnicity, geographic location, the time since stroke, and the diagnostic criteria used. PSCI predominantly affects survivors of acute ischemic stroke, or AIS. The study analyzed 951 patients with a mean age of 65.7 years, indicating that older individuals are particularly vulnerable. Risk factors such as previous stroke history, hypertension, diabetes, atrial fibrillation, and cortical lesion presence were more commonly seen in those who developed PSCI. PSCI manifests as deficits in multiple cognitive domains, including memory, executive functions, visuospatial abilities, and language. Diagnosis is typically made 3 to 6 months post-stroke using standardized neuropsychological assessments. For this study, a significant deficit was defined by a Z-score of less than -2 in at least one cognitive domain. The development of PSCI is influenced by various factors, including the severity of and volume of stroke. The greater stroke severity and larger stroke volumes increase the likelihood of PSCI. Brain atrophy. Mesial temporal lobe atrophy plays a significant role. Age and comorbidities, older age, high fasting blood glucose levels, and conditions like atrial fibrillation and critical contributors. And then finally, lesion characteristics. The presence of cortical or strategic infarct significantly impacts cognitive outcomes.
Okay. And then, so touching on the background, so we understand that we have post-stroke cognitive impairment, also known as PSCI, is going to be a common challenge. It's going to affect up to 50% of individuals who experience an acute ischemic stroke because cognitive recovery can significantly impact quality of life. Being able to predict cognitive outcomes after a stroke is crucial for making informed treatment decisions and planning rehabilitation strategies. This study focused on a group of patients with PSCI and explored whether machine learning techniques could be a reliable tool for predicting who is at risk of developing cognitive impairment following a stroke. So I wanted to focus on pathways first. So this is going to be kind of an overall pathway for the first one for an ischemic stroke. And so the core, if you look into the core, it suffers immediate damage while the penumbra is salvageable for hours. The excitotoxicity occurs when excessive glutamate overstimulates NMDA and AMPA receptors, leading to calcium overload, ROS generation, and mitochondrial dysfunction. This activates downstream pathways, including Kaplan's, CAPCs, and inflammatory cascades, which is going to worsen neuronal death. Targeting exotoxicity via glutamate antagonist calcium modulators or antioxidant therapies shows promise in mitigating damage. Right, and then moving on to this one, it seems like a lot, so I'm going to try to break it down the best way possible. So during an ischemic stroke, the brain is starved by oxygen and nutrients, which is going to kick off a chain reaction of signals that either try to protect or lead to their death. So the HIF1 pathway helps cells survive by switching them to emergency energy production, like a backup generator, when oxygen is low. However, this process can create harmful molecules like ROS, which damage cells further. On the other hand, the NRF2 pathway acts as a brain defense system, reducing this damage by turning on antioxidants and keeping the cell's energy powerhouse, the mitochondria, healthy. And so the CK2 plays a mixed role, sometimes helping clean up harmful molecules, but other times accidentally making things worse by encouraging cell damage. The brain also has a cleanup system called mitophagy, which removes damaged mitochondria to reduce the buildup of harmful molecules and keep cells alive. In the stroke's most damaged areas, cells usually die permanently, but in less affected areas, programmed cell death processes like apoptosis or autophagy, which might allow for some recovery. Together, these systems highlight how the brain fights to survive and recover, while also showing potential targets for treatments to protect brain cells during a stroke.
Okay, then looking at methodology. So this study used a retrospective design based on prospective acute registry. It aimed to predict PSCI in patients with AIS using machine learning models. The 951 patients included were admitted within 7 days of symptom onset between January 2011 and December 2020. Patients underwent cognitive assessments 3 to 6 months post-stroke using standardized neuropsychological tests. Several clinical and demographic factors were analyzed to predict PSCI, including baseline and demographics, which included age, sex, and education level, the National Institute of Health Stroke Scale, the NIHSS. The median scores were used to assess initial stroke severity. The higher your NIHSS score, the greater the stroke severity indicated. TOAST classification, the trial of ORG 10172, an acute stroke treatment, or TOAST, system classified stroke subtypes into categories such as large artery atherosclerosis, small vessel occlusion, and cardioembolism. Lesion location and size, the stroke volume, and whether the infarct was cortical, subcortical, or infratentorial were recorded. Mesial temporal lobe atrophy. The severity of atrophy was scored using Schletten's scale. The laboratory glucose levels, blood glucose levels were tested, and elevated fasting blood sugar was associated with higher PSCI risk. Cholesterol and creatine levels were also tested, but had a lesser impact compared to the glucose. And then finally, vascular risk factors. So the presence of hypertension, diabetes, and atrial fibrillation increased PSCI risk, as well as the history of stroke or transient ischemic attack, or TIA, were predictive factors. And then to look at the machine learning models that were used, the first one was logistic regression, or LR. It was used as a baseline model to predict binary outcomes by transforming a linear combination of variables and probabilities using a logistic function. The second one was called support vector machine, or SVM, which identifies an optimal hyperplane to classify data points. It is well suited for binary classification problems and works in high dimensional spaces. For the third one, the extreme gradient boosting, or XGBoost, was an ensemble model that builds decision trees sequentially, each correcting errors from the previous one. XGBoost was the best performing model with an area under the curve of 0.7919, indicating strong predictive accuracy. And then the final one was the artificial neural network, or the ANN, which comprises multiple layers of interconnected nodes to model complex nonlinear relationships. It achieved an AUC of 0.7365, showing robust but slightly lower performance than the XGBoost. And then to look at the model optimization techniques, the first one was the stratified k-fold cross-validation, which ensured that data set was split into training and testing sets while maintaining the class distribution. The second one was the random search with Aptuna, which hyperparameters were optimized using random search rather than grid search, which yielded a better performance. And then finally, the SHAP values, which used to explain the contribution of each variable to the model's predictions, highlighting the impact of stroke severity, lesion location, and age as critical predictors.
And Okay, so looking at results, out of 4,329 patients admitted for acute stroke during the study, 950 were included in this analysis. Their average age was about 65.7 years old, and the neuropsychological assessments were done about 4 months after their stroke. The median NIHSS score in this group was 2. Among these patients, 286, which is about 30%, developed post-stroke cognitive impairment within 3 to 6 months. Based on the KVCIHS-NP results, key differences between those with and without PSCI are shown in. PSCI are more likely to occur in older patients and those who are cardioembolic strokes. Higher initial NIHSS scores are going to be larger stroke volumes and cortical or strategic lesions. The PSCI group also had a higher rates of hypertension, diabetes, coronary heart disease, arterial fibrillation, prior stroke or TIA, and elevated fasting blood glucose and MTLA scores. Now, we discussed how XGB had more accurate results, so I wanted to focus on the results that they got. And so we see that the severity of the stroke measured by the NIHSS score at discharge and stroke volume turned out to be the most important factor. Medial temporal lobe atrophy came next, and then followed by age, fasting blood sugar, depression, and cortical lesions. The model also considered a history of previous strokes and arterial fibrillation. Interestingly, left-sided lesions or multiple territorial lesions didn't seem to matter as they had no SAP value. Other key factors identified across different machine learning models included cortical lesions, stroke severity, medial temporal atrophy, previous stroke, and strategic lesions, along with arterial fibrillation. And so to overall wrap up the main findings that we saw, this study used machine learning to predict cognitive decline, which, as we've been talking about this whole time, PSCI, in people recovering from a acute stroke. Among the models tested, XGBoost was the most accurate, and the most important factors of predicting PSCI were the severity of size, of the stroke, brain atrophy, age, blood sugar levels, and cortical damage. While models like Change and Signal 2 had slightly higher accuracy, this was the first time the study was able to combine detailed clinical and imaging data to make these predictions. Most of the key factors like age and previous strokes can't be changed, and it's unclear if managing things like diabetes or high blood pressure can actually prevent PSCI. However, identifying patients at higher risk could help doctors catch and address cognitive issues earlier. More research with larger groups and advanced imaging could improve these predictions further.
Okay. And now we are going to look at a different article to support our main article. This article was by Jiahao Sun, and it was called Post-Stroke Cognitive Impairment Mechanisms and Management. So to support the findings of our main article, both articles emphasize the high prevalence of PSCI ranging from 20% to 80% depending on geographic location, ethnicity, and diagnostic criteria. They both highlighted risk factors such as age, education levels, and comorbidities like hypertension, diabetes, and atrial fibrillation. The article by Sun underscores the role of neuroanatomical lesions, particularly those in strategic areas like the hippocampus and white matter lesions, in the development of PSCI. Similarly, our study identifies cortical and strategic infarcts as key predictors using machine learning models, reinforcing that lesions' characteristics significantly influence cognitive outcomes. Both studies recognize brain atrophy, particularly in the mesial temporal lobe, as a significant contributor to cognitive impairment. The presence of vascular risk factors such as cerebral microbleeds and white matter lesions further support the mechanistic link between vascular damage and PSCI. While Sun does not directly explore machine learning, it detailed analysis of risk factors, lesion location, and vascular contributions aligns with the input variables used in our main article's machine learning models. This connection validates the predictive potential of such models in identifying high-risk patients and highlights the integration of clinical and imaging data as crucial for improving predictions. And now to look at our conclusions. So PSCI affects 20 to 75% of AIS survivors, making early prediction critical for targeted intervention. And then secondly, factors like stroke severity or the NIHSS scores, stroke volume, mesial temporal lobe atrophy, fasting blood sugar, age, and cortical infarcts emerge as the most critical predictors of PSCI. Third, the extreme gradient boosting, the XGBoost model outperformed others, achieving the highest accuracy in predicting PSCI outcomes, validating the advantage of ensemble models over traditional logistic regression. And then finally, supporting studies confirmed the importance of lesion location, vascular risk factors, and neuroimaging variables in PSCI prediction, strengthening the model's clinical relevance. And then important next steps in PSCI research. So the first one would be incorporating raw MRI data such as diffusion tensor imaging and functional MRI, which could enhance understanding of network connectivity disruptions. This would allow machine learning models to capture more nuanced relationships between lesion locations and cognitive outcomes, potentially improving prediction accuracy and uncovering additional risk factors. Secondly, expanding the study to include multi-center datasets with diverse populations is critical for external validation. This step ensures that the machine learning models generalize across different ethnic, geographic, and clinical settings, thereby increasing their reliability and clinical utility. And then third, conducting longitudinal studies to track cognitive outcomes beyond the current 3 to 6 month window would provide insights into long-term PSCI trajectories. Additionally, testing whether early ML-driven interventions such as cognitive rehabilitation or aggressive vascular risk management can mitigate PSCI would be a pivotal step in translating predictive insights into benefits. And then finally, implications for neurobiology and clinical practice. So the first one would be the identification of key predictors, such as mesial temporal lobe atrophy and stroke severity, provides insights into the neurobiological pathways underlying PSCI. It highlights the role of network disconnections and vascular damage in cognitive impairment, contributing to the broader understanding of how stroke affects brain connectivity and cognitive function. Secondly, machine learning models offer clinicians the ability to predict PSCI risk early, allowing for personalized management plans. High-risk patients can receive targeted cognitive rehabilitation or vascular risk control, potentially mitigating cognitive decline, improving long-term outcomes in stroke survivors. And then finally, the use of explainable AI tools like SHAP values enhances their interpretability of complex ML models, making it easier for clinicians to understand which variables contribute the most PSCI risk. This fosters trust in AI-driven tools and facilitates their integration into routine clinical practice for improved cognitive outcome predictions. To conclude, this research is significant because it leverages machine learning to predict PSCI, addressing for a critical need for early identification of cognitive decline in stroke survivors. By integrating clinical, demographic, and imaging data, it enables personalized interventions, potentially mitigating long-term cognitive deficits and improving patient outcomes in a condition that affects up to 75% of stroke patients.
Okay.
Thank you.
Thank you.
We're excited.